welcome everybody, and good morning or good afternoon, depending on where you're joining us from. And welcome to this new autumn series of the Info Masterclasses. Before we ask Simon to take the floor and actually give the proper masterclass, I need to give you some very few instructions regarding the Q&A. You will not be able to interact directly with us. The only way to interact with us is through the Q&A box or through the chat. So after Simon will look on his lecture, I will be moderating and reading the questions for him. Now that said, I'd love to introduce you to Simon Freeman, who is an otolaryngologist at 2 hospitals in Manchester, and who is part of the big NF2 multidisciplinary team that is a reference center in Manchester for NF2. So without lingering too much on this, welcome Simon, and thank you for being here today. And the floor is yours.
Thank you very much, Marco. Great. So I'm going to talk today about optimizing hearing outcomes in NF2-related schwannomatosis. And being an ENT surgeon, which is the lay term for an otolaryngologist, hearing is very close to my heart. So hearing loss is extremely important in NF2. When quality of life studies are carried out, we usually find that hearing is one of the, if not the most important factor to NF2 patients. And unfortunately, it's almost inevitable as the disease progresses, and therefore the rehabilitation is extremely important in trying to maintain quality of life. So what's the problem? Well, the picture gives it all away. Unfortunately, almost everybody with NF2 will develop bilateral vestibular schwannomas by the age of 30. There are occasional patients with mild mosaic disease who only get unilateral, but almost everyone else gets bilateral. And vestibular schwannomas cause hearing loss. You know, they're situated on both the cochlear nerve and the labyrinthine artery, which is the blood supply to the cochlea, and they can affect function of the inner ear via damage to both, even if they're not growing. And growing tumours, of course, may require hearing destructive treatments. You know, the picture demonstrated shows how dangerous these tumours can get if they undergo sustained growth and that growth is not controlled. So a lot of what we're really talking about is trying to balance optimizing the hearing function with against trying to make sure the tumours are controlled. So I've just showed here a table of the NF2 genetic severity score we use. So 1A, 1B, 2A, 2B, and 3, and it gets more severe as it moves down the table. So 1A and 1B don't have a blood diagnosis, and then 2A, 2B have blood diagnosis and tissue diagnosis and more severe mutations. The reason I'm showing you this is because we did a study in the last few years that looked at the growth rates and behaviours of untreated vestibular schwannomas in our population. And you can see the different severity numbers in different colours. And what this demonstrates is that patients in the less severe scale, so particularly 1A, 1B, well, there's a lot of patients aged between sort of 40 to 70 who still have untreated tumours. So we can be fairly sure in those patients that we're going to be able to manage them with sound amplification and not require more destructive treatments. Whereas if we look at the other end of the scale and the patients in black, these patients have all had their tumours treated beyond the age of 30. So again, that gives us a very good idea of prognosis. whereas the groups in the middle, 2A and 2B, have a scattering across the table. And so some of those patients will remain without the need for treatment in their vestibular schwannomas, but some will not. Now, just to give an idea of numbers, this is another study from 2014 of the UK population. And at that point, this was where patients fell in terms of their better hearing ear. So you can see that 70% of patients had good hearing in at least one ear, okay? Whereas at the other end of the scale, we see that a quarter of patients had very poor hearing in both ears and either had no hearing or required a hearing implant in order to be able to hear. So just thinking about how we assess hearing before we move on. So with vestibular schwannomas, they affect not just the threshold of hearing, but they also affect the ability to discriminate speech, which is a slightly different thing. So we need to use 3 different tests. So a pure tone audiogram assesses the threshold of speech. A standard speech audiogram assesses speech discrimination. And then we have an aided test, which tests how well a patient does with their hearing instrument, either a hearing aid or an implant. So how do we do these? Well, this is, the standard testing for a pure tone audiogram or an unaided speech audiogram is in a sound booth without aids. And this is what we end up with. So in a pure tone audiogram, we've got lots of different frequencies across the bottom of the table. And then this is the threshold of hearing. And we end up often talking about a 4-frequency average because those are the main frequencies of speech. And then the speech audiogram, we test monosyllabic words, so that's single syllable, so cat, dog, bat, etc. And the current ones we use are called the AB words, and we test people on the percentage that they get correctly at different loudness thresholds. So you can see the loudness going up at the bottom of the graph, and on a normal patient with normal hearing rather, you can see rapidly they get up to 100%. And we tend to talk about the best percentage, so there are different ways of describing that. Now, if someone has a conductive loss, or some people with sensory neural loss, they'll still get to 100%, but they require a louder threshold. But the green is what can happen with vestibular schwannomas, and we call that the rollover phenomenon. And that's because it disproportionately affects speech discrimination. So you can see it reaches a maximum, but then as it gets louder, the discrimination actually gets worse rather than better. So we have to take that into account when managing hearing. And then the final test is how well someone does with the actual hearing instrument. So in the picture, this patient is wearing a cochlear implant, and we use the same monosyllabic words currently, although that's changed, and we used to use a sentence score. But essentially, this is delivered at a single volume, and it's still a percentage of how many phonemes they get. A phoneme is a sound in a word, so cat would be k, a, t. And this allows us to test both hearing aids and hearing implants, such as cochlear implants and auditory brainstem implants, so that we can both work out who's in criteria and also work out how well they're doing post-implantation. You can also see there's a video here, and that allows us to test lip reading skills as well as hearing skills. And that test is called the CUNY sentences. So, and I'll touch on that a bit later. And that's important for people that don't do very well with their hearing implant, but you can start to see how well they do when you combine lip reading with hearing. So just thinking back to our NF2 population, we've got a large proportion of that population have one good ear, but many of them won't have a good second ear. So they'll fall into this group of unilateral severe deafness. And that brings up sort of, I say minor issues, because of course they can still have normal conversation and communicate in normal ways, but they're more subtle issues. So if someone speaks to them on their deaf side, they don't take that in so well, and they may not hear someone at all. And then in more complex situations, such as background noise, they can't hear nearly as well, and they can't tell where sound is coming from, because you need two ears to be able to do that. But of course, that's a very different situation to the bilateral severe deafness that 25% of our NF2 population suffer. Because of course, if someone's been born hearing and learnt to communicate through speech, then to suddenly remove that hearing can make communication extremely difficult. And it also takes them away from their environment. They can't tell, even basic things like the doorbell ringing, etc., etc. And as time progresses, it may even start to affect speech production. So there are a number of rehabilitation options we have. Standard hearing aids, which are pure just amplifiers, basically. So you need a certain level of hearing to be able to use a hearing aid. And then if you have one-sided severe deafness, we have something called contralateral routing of sound to the other ear. And that might be a hearing aid where you've got a normal hearing aid on the good ear, but a processor and a microphone on the bad ear, and it sort of wirelessly sends sound to the good ear. So you're still only hearing in one ear, but at least you can tell what's going on the other side. There are different types of that. And then we've got the implantable devices, the cochlear implants and the auditory brainstem implants, otherwise known as ABIs, and I'll talk about those in more detail. So this talks about cross-aiding. So you can see that just what I was just talking about, it's sending sound to the other ear. And then we've got something called a bone conducting hearing aid. So these are implantable devices that stimulate sound. They send the sound into the bone essentially, and so it crosses through the bone to the good ear. And that means they don't have to wear a hearing aid blocking up their normal ear. And there are lots of different types of bone conduction aid nowadays. There are several different types of surgically implantable aids. So these are bone-anchored hearing aids. This is the new cochlear ossea. And then you've got sort of conservative ones where things are just pressed against the skin. And as I mentioned, these allow people to tell when someone's speaking on their deaf side where they otherwise wouldn't hear them, but they don't give great improvement to the more complex sound localization or speech and noise. And it's quite variable how many patients find this beneficial. The take-up rate's often about 50%. Some people find it very helpful and some people don't. And it largely depends on what people are doing in their everyday professional and personal lives. But if we move on to the more complicated cochlear implants and auditory brainstem implants. So this is showing the hearing pathways. And so this is a sort of diagram of the cochlea. So a cochlear implant comes into the cochlea, and an auditory brainstem implant is used when the cochlear nerve has been damaged. So, for example, a tumor has been caused damage to the nerve, or more likely our treatments have. And then the ABI rests against the cochlear nucleus, which is in the brainstem. So that's the next step of the hearing pathway. And it just has a paddle which rests on the surface next to the cochlear nucleus. So this is what a cochlear implant looks like. These are the three different manufacturers, and you can see that they're all largely the same. They have this package which sits under the skin, and then an electrode which winds through the mastoid and is just threaded through the cochlea. And here it's in place. You can see this is the bit that's under the skull. next to the skull under the skin, and you can see this wrapping around the cochlea. And then we have this external component, which is a sound processor, and this has a magnet in it, as does the internal bit, so then it transmits information transcutaneously to get things to work. And the reason cochlear implants work so well is because of the tonotopic arrangement in the cochlea. In other words, where the pitches are heard. And the cochlea is hardwired to the brain so that the basal turn hears high frequencies and the apical turn hears low frequencies. So we know that speech sounds have fundamental frequencies within each sound. And so our electrode can stimulate the specific point in the cochlea that would recognize that frequency of sound, and that allows then the brain to appreciate how the speech sound should sound, and that makes them very effective at reproducing speech sounds within the cochlea, even when the cochlea doesn't work. So just coming back to our criteria, just to show what our usual criteria in the UK is, and of course it's going to be different around the world, but this is our pure tone audiogram. So it's basically for people with severe to profound hearing loss in both ears, usually, although in NF2 it's not quite so clear cut because of the risk to the other ear from the tumour. But essentially there's a pure tone audiogram criteria, and there is a functional criteria. And our old criteria used to be on BKB sentences with just a small corner of hearing, and now we're more open because we know that they work really well. And generally speaking, we expect patients to get about 80% or better rather than the 50% criteria. So just to show some historical data, this is based on BKB sentences, and you can see that over time, as it progressed, our averages got better, and that's because the speech processing strategies improved over the years. But you can see the vast majority of patients do really well, and by 2012, the average user was getting 80% on their BKB sentence scores. But remember, these were non-NF2, non-tumour patients. So this is the ABI, and you can see the difference. It's essentially the same as a cochlear implant, but the electrode is a paddle rather than just a straight electrode, and that paddle has all the electrodes on it, and it's just placed against the brainstem, against the cochlear nucleus. There's a little recess called the foramen of Luschka, in which you can place the paddle to hold it reasonably securely. But ABIs don't work as well as cochlear implants, and the main reason for that is because the tonotopic arrangement in the cochlear nucleus is much more complicated than it is in the cochlea, and it's essentially distributed anatomically in 3 dimensions rather than in a linear fashion. So it's much harder to recreate the specific pitches of speech with an ABI than it is with a cochlear implant. And this is just showing the results from our study a few years back, where we looked at our first 50 cases. And so this was with their word score. So you can see most people were getting between 5 and 10% with the ABI alone, so much worse than a cochlear implant. This was what they tended to get with lip reading. But if you put the two together, they seem to have a synergistic effect. And suddenly people are scoring from sort of 50, 60, 70%. And that means that you can have a one-on-one conversation, as long as someone can read your lips without having to write things down. And it allows them to recognize some environmental sounds. So it brings them in contact with their environment in a potentially useful way. Now, there is quite a high non-user rate, unfortunately, and that probably relates to the complex anatomy of the cochlear nucleus. So essentially roughly 20% don't get use of the device. But on the flip side, we also get about 1 in 10 who get a result that's comparable with a cochlear implant, and they're getting more like 60 to 80% speech discrimination with their ABI alone. I've touched on sleepers here. So a sleeper is where we put it in where they've still got hearing on the other side. So if I move to this slide, just talking about in NF2 who gets an ABI, well, essentially anybody who we're going to do a surgical resection of tumour where it's not suitable for cochlear nerve preserving surgery, and I'll come on to that in a bit, then we're going to think about putting an ABI in. And if that's someone with bilateral hearing loss, profound loss, then we call that their second side. It may be their first ABI, but otherwise we call it a first side. And that's because if they've still got hearing, almost nobody uses the ABI, even though we try to encourage it, but it just, the level of hearing that it provides just isn't, the patients just don't feel it's worth the effort. But it does, the reason we do it is because of this 20% non-user rate, potentially it gives people the option of 2 bites of the cherry. So you can have, if the first side doesn't give you any stimulation and we end up taking the second side out, then we could potentially do another ABI. Now, before we go on beyond this, we need to start thinking about tumour management, because as I said at the beginning, really the balance with NF2 is trying to gain control of the tumours that are growing while trying to maximise our hearing. And fundamentally, there are 4 management strategies that we could employ: conservative, medical, and we now have this excellent monoclonal antibody bevacizumab, which not only does not damage hearing, but it potentially can improve hearing. In the UK, we only use it for faster growing tumours because our feeling is that it's less effective on slow growing tumours. And then we have radiotherapy, which most people would use a single fraction stereotactic radiosurgery, or SRS as it's known. And this potentially can preserve hearing, but it can be hearing damaging. It anatomically preserves the cochlear nerve, although it can cause damage to the cochlear nerve. And of course, it has its own issues in terms of limitations on tumour control and potential for creating new tumours or potentially even malignant transformation in a tumour-prone condition such as NF2. But then, of course, we have surgery, and principally, most surgery would be resection of tumour with cochlear nerve, and that's because it's very difficult to preserve the cochlear nerve in medium and large tumours. It's essentially, the cutoff's about 1 centimetre diameter. But we also have the option of trying to preserve cochlear nerve in smaller tumours, or even hearing preservation surgery. Now, it's always a difficult one, because, if you try and do these things in someone with hearing, you're taking a big risk, because you could end up with the worst of all worlds, where you don't preserve the cochlear nerve and they lose their hearing. So we tend to use the cochlear nerve preserving surgery when someone's got a small growing tumour, but they've lost their hearing already. And we tend not to do hearing preservation surgery in NF2 anymore, but certainly other centres around the world do. And that brings us on to this rather complicated table, just sort of putting all this in perspective. So this is for small tumours, So on the left of the table, we've got stable tumours with good hearing. Great, we don't need to do anything. But if they've got poor hearing, well, that's fine. We can put a cochlear implant in. But if we've got growing tumours, we need to get tumour control. So if we've got good hearing, well, either medical therapy with bevacizumab, or we've got radiotherapy, or we've potentially got hearing preservation surgery, or if it's small enough, well, that's this group, we could try and preserve the cochlear nerve with a translabyrinthine resection. And if we don't preserve that, we can put an ABI in at the same time. If we've got poor hearing, then with SRS or medical therapy, we can do the same, but just put in a cochlear implant. Or we've got the option of trying to preserve the cochlear nerve. And again, if not, then we've got the ABI. With larger tumours, things are different because we lose the option of hearing preservation or cochlear nerve preserving surgery. So you can see that the stable categories are still the same, but this time we've just removed those other categories. And it's worth bearing in mind that SRS is not really suitable for large tumours because of the potential effects on the brainstem. But you know, there's often no absolutes, and everything's weighed up with taking the patient and all their issues as a whole. So just in terms of cochlear implants specific to NF2, as I said, cochlear implants give much better outcomes than ABIs, but when you've got a tumour that's potentially affecting the nerve and you have to take into account the different tumour control modalities, what does that mean? So I'm just going to quickly run through the UK study that we published recently, and this looked at all the implants that we'd done over a 15-year period in the UK, predominantly England. And we looked at, so we had the BKB sentences and CUNY, so that's the ones with lip reading. And Q means in quiet, and N means with background noise, so that's a harder test, and whether people use the device. So the tumour treatment modalities broke down into all the ones that I've talked about, and there were a few patients that had multiple modalities. And then in terms of the results, mean durations of the duration of profound deafness was quite variable, but on average was quite low. And as you can see, most patients were deaf in both ears because the average was 94, although there were the odd patient who still had hearing in the other side. And so you know, you could call that a sleeper cochlear implant, but actually sometimes the patients are more likely to use a cochlear implant than an ABI. Tumour can get into the cochlea, and in these cases, usually we just implant through the tumour. The tumour is very soft and it's usually not an issue. And most patients achieved a full insertion. But 17% got no benefit from their cochlear implant. So even though anatomically the nerve might have been intact, it may not have been functionally intact. And you can see that predominantly that's surgery. So although at the end of the operation it looked intact, it probably had been damaged microscopically. But overall, here are the results. And you can see that patients who had not had any treatment do pretty well. So they're getting, you know, scores of 65% on average. So it's not too far off, and not scores from non-tumour patients. And the patients that had been treated that got benefit were all fairly similar in this sort of 35 to 50% bracket. So a reasonable outcome, but not as good as standard as non-tumour patients. But still a pretty beneficial outcome. And this just shows change over time. And you can see that unfortunately, some patients do drop off over time. And sometimes that's because we end up needing to treat the tumour. But sometimes it's just because things seem to have deteriorated, and particularly if someone's had treatment with radiotherapy and sometimes surgery, you know, our assumption is that there's scarring that develops, and that starts to affect the function of the nerve. We looked at all sorts of different factors that might have been predictive, and the ones that we expect, things like tumor size and duration of profound hearing loss, had a little bit of an association, but they weren't associated in both groups. And so, you know, fundamentally, it's quite difficult to predict. And, you know, we tend to just, if we think a patient's suitable, we tend to just go for it and hope for the best. And when we compare our series with the literature, we can see that things are very similar across the board. So, you know, roughly 70% if they haven't had other treatments, and roughly, you know, 35 to 50% if they have had treatments, and that's significantly better than the ABI, which tends to come in at about 10%. So just to conclude, there are lots of factors that we need to take into account when we're trying to optimize hearing. You know, what's the hearing like both in the ear that we're treating and in the other ear, to give an overall hearing ability of the patient. You know, how are we going to manage a tumor? What's the previous treatment? What's the cochlear nerve status? Can we preserve the cochlear nerve with our different treatment modalities? You know, how big is the tumor? How fast is it growing? And what management options are available? So for us, you know, our default position for a growing tumor will be Avastin, because it's potentially hearing and hearing nerve preserving. But, you know, we're only funded to give it on faster growing tumors, so that, you know, it's just not available for some patients. And then we also need to take into account other things. So, you know, what's someone's general health and disease burden like? Is that going to prevent us from doing certain operations? And you know, obviously a patient's wishes are paramount, and, you know, a lot of this, we have options, but we just have to sit down with the patient and discuss them in detail, and come to a joint decision. And that is the end of the talk.
Thank you very much, Simon. It was very clear, at least to me.
Excellent.
I don't see any questions in the chat yet, either in the chat or in the Q&A box. Please remember, all attendees, that you are more than welcome to ask any questions to Simon. I actually have a couple of questions myself to start with.
Go for it.
You mentioned that hearing preservation surgery is not really followed anymore as the best option in the UK, at least. Could you explain the reason why?
Yeah, I think there's a few reasons, really. So in order to do hearing preservation surgery effectively, there needs to be certain configurations anatomically of the tumor. So there are two different surgical approaches that can preserve hearing: the middle fossa approach and the retrosigmoid approach. So the middle fossa approach comes in from above, and that allows access to the internal auditory meatus with very limited access to the posterior fossa. But the problem with a middle fossa is the facial nerve is in your way. And that technically is very difficult, particularly if you don't do a lot of it. And, you know, we stopped doing it just before I started practicing, actually. Sort of came to the conclusion that we were only doing it on small numbers. The results weren't as good as we would have liked. And therefore came to the conclusion that the middle fossa wasn't for us, for any vestibular schwannoma surgery. And all the other centres in the UK, you know, all those respective surgeons have come to the same conclusion. So with vestibular schwannoma surgery, we use the retrosigmoid if we're going to try and preserve hearing, but that you can only get you can't access the whole internal auditory meatus via that approach. You can't access the lateral part, which means you need a tumor not to have filled the whole internal auditory meatus. And unfortunately with NF2, that's almost never, because of the sort of multifocal nature of the tumors. You know, we published a few years back on our children that we'd started scanning from the age of 10, and you could see all these dots appearing on the vestibular nerve, and they just appear all the way up the IAM. And so, you know, that's why. So we just decided that actually that's probably not a great option for us, because we're going to leave tumor behind, and that's not great. So what we ended up deciding was we'll do our usual translabyrinthine approach, which accesses everything, and that then potentially allows us to preserve the cochlear nerve, which allows us to use a cochlear implant. So that's almost our sort of surgical hearing option. It's not the same as hearing preservation, of course.
Now, there are questions coming up in the chat, thank you. But this actually led to another question of mine, which I'd rather ask first. And it's this functionality of the nerve versus the presence of the tumor. What isn't clear to me, and I wondered if you could give us some insight into, is how associated is the hearing loss to the presence of the tumor itself, or has anything been studied or done to try to understand if the two things are de facto independent?
So they are surprisingly unrelated.
Yeah.
Because, you know, you would have thought, particularly when we look at, you know, the historical speech discrimination, and, you know, I described that rollover phenomenon where you only see that with a retrocochlear loss, i.e. a tumor on the nerve. So we're going, well, that must be therefore affecting the nerve. And up until, you know, sort of 2006, therefore, the feeling was there was just no point putting a cochlear implant in, because the nerve wouldn't work if someone was deaf. And it wasn't until we just started doing it that we were somewhat surprised to see that actually most of them work. And we don't have a very good explanation of that. You know, functionally, the nerve must be affected by hearing because of this rollover phenomenon, although, you know, predominantly when someone loses hearing, that's probably because of a damage to the cochlea rather than the nerve. And, you know, I conclude that because cochlear implants work. But, you know, the fact is, when you put an electrical stimulation in, it usually works. And in terms of tumor growth to sort of hearing function, we find in our sporadic population that there's actually not a good correlation between those two. And you know, I'm always telling patients, if your hearing drops, don't think that means your tumor is growing, because more often than not, that's not the case. The only way to tell growth is on the scan. And equally, growing tumors don't necessarily cause hearing loss.
Thank you. Now we have questions popping up. The first ones are from Amedeo Azizi. He wondered if you could speak about if you are managing children and adults differently, or if it's the same path that both follow.
So, I mean, fundamentally, it's the same path. The difficulty with children is often more to do with the severity of disease rather than the age of the patient. Now, you know, I mean, of course, children are not adults, and the whole sort of holistic management is different. You know, we have children's oncologists, adolescent oncologists, and adult oncologists who work, you know, who have their own practices. And so when, you know, when we're using bevacizumab, they will be seen by the specific oncologist. We have children's surgeons as well as adult surgeons. So holistically, children are managed with different teams, although there is quite a lot of overlap. But in terms of the questions of management, it's more about severity of disease, because the children that need managing are the patients with severe disease, and they tend to present, the patient, you know, the category 3 patients tend to present in their teens with, you know, nasty, rapidly growing tumors. And so those are the ones where you're starting to have those difficult conversations with. But, you know, bevacizumab has been a game changer. You know, when I first started prior to bevacizumab, you know, the devastation psychologically on those teenagers that suddenly found themselves having to have both ears operated on, lose all their hearing, ABIs that might give a bit of function, versus to now being able to manage people with bevacizumab is fantastic.
Thank you, Simon. There's actually more or less the same question coming up from both Amedeo Azizi and Ignacio Blanco, wondering, is radiotherapy still a good option? I mean, do you see malignization after radiotherapy at times?
Do we see
tumors becoming malignant after?
Oh, yeah. So, you know, that's been a long-standing debate in the NF2 community for many, many years. I mean, Manchester historically hasn't tended to use radiotherapy for NF2 as much as other centres because of concerns of, predominantly around malignant transformation. We have very recently published a paper where we have found evidence of malignant transformation rates as high as 5 or 6% following radiotherapy, which obviously is much higher than we see with sporadic tumours, and certainly is something that causes concern. But that does not mean that SRS is not a reasonable option. You know, that means 95% do fine and don't have that issue. So it's more about balancing all the issues with all the different treatment modalities. And as you know, as I said at the end, sitting down with the patient and going through things in detail, because they're really complicated, and just trying to gauge a patient's wishes. You know, SRS, I've seen some very good outcomes with SRS, where, and even in the younger patients, where the nerve's been preserved, hearing was preserved for some time, but then went off, but then we could put a cochlear implant in, and they've had good benefit from that. So, you know, there's no straightforward answer, and SRS is definitely on the list of possible options.
Thank you. There is a question from Gianluca Piccolo, who is present at almost every info masterclass with us. He is wondering whether how do you balance, you know, the need for improving hearing with and so to use implants, and the need to have MRI follow-ups, and
no, good question. I did not touch on MRI, so that's really important for NF2 patients. So, again, when I first started, the cochlear implants had a removable magnet. So we had to do a little operation. So if the patients that had implants, we'd try and manage it with CT with contrast. It's not as good. And we tried, and so if we needed to do an MRI, we'd do a little operation. We'd take the magnet out, do the scan, put the magnet back in, close it up. That has some risk to the implant, particularly the housing that carries the magnet. But then in the sort of fairly soon after I started, we started using a head wrap protocol. So we put we make a mold using hearing aid mold, and we set that over the implant, wrap a very tight bandage, and that holds the magnet in place and allows us to do a scan without the magnet becoming displaced, although there is still a small risk of it. And actually, because of where the magnet is, sort of higher up on the head, we still get a good view of the posterior fossa. And it's quite unusual for us not to be able to see sort of tumours in that location. You do get a significant artifact around the parietal area. So if we have tumours in that area that we need to look at, then you have to use a CT with contrast. But actually, in the last sort of 4 or 5 years, the implant companies have created these implants which have very clever rotating magnets, and now they're all MRI compatible. We don't have to do head wraps. So the only issue is the artifact. And as I say, we always, with NF2 patients, we always try to set the magnet as high as possible on the head to try and minimize that. And most of the time we're okay.
Well, actually, this raises a very practical issue, which has enormous practical implications, because as Gianluca rightly says in the chat here, he says most centers do not advocate to neurosurgeons, and many people seem to end up in a situation where the center refuses to do an MRI on a patient. Because this webinar will be recorded and posted, for people to know, so that anyone can watch it, even those who are not attending today. What advice would you have for doctors to try to implement a system that is safe for everybody, and in a center where which is not the Manchester NF2 reference center, where you may not have all the necessary skills?
No, absolutely. So that's been a very long-standing issue with anyone with a displaceable magnet. We have always insisted in our cohort that we scan them. Now, actually, as more and more cochlear implant patients have required scanning, last year, I think it was last year, maybe in the year before, we got together with the British Cochlear Implant Group, a large number of us around the country, and have created a teaching package to explain exactly what the issues are, how to head wrap, which implants need head wrapping and which implants don't. And all of these resources are freely available on the British Cochlear Implant Group website. So if you want to start a practice where you want to be able to scan these implants, go down to your radiology department, make contact, all get onto the British Cochlear Implant Group, read look at the videos. They're all pretty clear, and also make contact with the companies, because the most important thing is you need to know exactly which implant it is, because there's quite a lot of differences because of this. Some are displaceable and need head wrapping, some aren't displaceable but still need head wrapping, some don't need head wrapping, and the really old ones aren't MRI compatible at all. So you've got to know. And that means you've got to be in touch with the Cochlear Implant Centre that did the implant in the first place.
Well, thank you for this very clear answer. And thank you, Gianluca, for this actually very, very relevant question. I can't see any other questions coming up. So we still have 10 minutes, and I'd really love to hear about your experience with bevacizumab. And I wondered, for those patients, I mean, if you have experience with patients who have been on bevacizumab and who nevertheless had to get an operation, had to get the tumor removed surgically afterwards, if that's influenced or not, I mean, the outcome of the operation and on the hearing outcome of the operation after the bevacizumab treatment.
So, the short answer is no. So, in our experience, so we always stop bevacizumab. God, God, I'm going to say 6 weeks before any major surgery, 4 weeks before any minor surgery. We haven't found any issues with operating on those tumours. It has been raised by colleagues around the world fairly recently, which made us have just to think about it and discuss it as a team, because I think it was Brad Welling that reported that they'd found some quite nasty vascular tumours in patients that had been on bevacizumab, but that has not been our experience, and we just haven't noticed any difference really when we've operated on patients prior to bevacizumab. We've always stopped it well before the surgery, as I said, so it should be out of the system. We haven't had to operate urgently. And the hearing wise, so I mean, as I said, because we don't do hearing preservation surgery, that's not really an issue. So the cochlear nerve preserving surgery has been so few, I can't think of any patient off the top of my head that had been on bevacizumab and then gone on to cochlear nerve preservation surgery. We've probably only done maybe 8 or 9 patients in total. However, what I will say is we do get the feeling that there is a good effect of bevacizumab with radiotherapy.
There you go.
So we've had, and that started with, we had one patient who was on oh no, he hadn't been on bev. He went on to have radiotherapy, and at 6 months his hearing in his one good ear, which is the one that had been treated, started to really go off. So we stuck him on dexamethasone, and we got permission to try bevacizumab, on the basis of rapidly reducing hearing, which is one of the indications for it. And his hearing came right back up, and we kept him on bevacizumab for 6 months or a year, I can't remember. Obviously the steroids only for a couple of weeks, and his hearing has stayed up. And so who knows, was it the steroids, was it the bevacizumab? We don't know. But since then, for any patient that's on bevacizumab, and we're not getting good control, and they go on to have radiosurgery, we keep them on the bev for the first year. Again, it's all anecdotal, but our impression is that we see less swelling, less complications, and less hearing loss. But we haven't properly analysed that yet. So we just don't have the numbers yet.
Great. Thank you, Simon. If no one has I can't see any other questions popping up, so I'll have another one myself, if you don't mind. We still have 5 minutes for this webinar. I was wondering if we could talk about a bit about standards for hearing outcomes. If how generalized the standards are in terms of measuring hearing outcomes in various countries, I suppose, and whether you could comment on the need to actually uniformize this or not.
So fundamentally everybody's doing the same thing in terms of a pure tone audiogram and then speech discrimination. The difficulty is that everybody's doing their own speech discrimination test. So, for obvious reasons, people that speak in different languages have to have their own validated speech discrimination tests. There's just no way of standardizing that, because the speech is so different across different languages. But even in the English-speaking world, which I use as an example because I'm more up on that. The Americans the North Americans will use different tests to the ones that we use. Fortunately, the UK standardized their speech discrimination tests a long time ago, but of course they're all the ones that were made by UK teams, and I'm sure there's a bit of people wanting to stick with their own tests. I mean, is there much difference between the different tests? It's very difficult to know the answer to that. I mean, when I read speech discrimination scores from other studies, but obviously let's take the ABI for an example. So there's lots of stuff come out from Germany, particularly, and from France, and they're using different discrimination tests to us now, but they also use different surgical techniques, and we've had a lot of discussion because a couple of the teams in Germany seem to get better results, and one of the theories is because they use the semi-sitting position for their retrosigmoid approach, and we don't. They're talking, and their theory is, does that mean that there's less congestion because there's less venous flow around? Our anaesthetists won't use it because of the risk of air embolism, so it's just it's not used in this country. But how much of that also might feed into the different speech discrimination tests that different people are using? Well, when the speech discrimination test between us and the French teams seem to give very comparable results. When we look at cochlear implants results, the speech discrimination scores actually don't seem that different. So I don't think it is. I think fundamentally the speech discrimination scores tend to be fairly similar across different languages and different tests even within the same language. And it probably more relates to other factors that we haven't quite worked out yet.
So the bottom line is you don't see an urgency to start uniformizing standards in terms of...
It's always good to uniform standards where possible. And that's why we have in the UK, trying to persuade colleagues around the world to do it becomes much more complicated. So while I think in principle it would be a good thing, I think in practice it might be a battle that's not worth trying to fight.
Well, thank you very much for this lively session, Simon. Our time is up. So unless you have anything else you wish to share with the audience?
No, I think all has been said, hopefully.
I thank you in the name of the patients, really, for your contribution today, and I thank the audience for being here and be very participative with their questions. This webinar will be posted on the Info YouTube channel as soon as practicable, please do check on our website for upcoming classes. The classes up to December have been programmed already, but we will shortly come with new classes for the beginning of 2024. And with that, I thank you. I thank everyone, and hope to see you soon.
Thanks very much, Marco.
Bye.
Bye.